Hello, everybody, and welcome to Realign Healthcare. I'm your host, Dr. Yauheni Solad, and we have a great guest with us tonight, Yulun Wang. Yulun, welcome to the episode. It's a true pleasure to have you here because we work together at Yale New Haven, and when I look at your illustrious biography and the things you built, I always wanted to ask a person who started doing robotics in 90s, telemedicine in early 2000, and actually sold a company, InTouch Health, in the midst of pandemic in 2020 to Teladoc when many companies just started doing active telehealth. So when you look back on your career, can you just reflect what helped you to start this and to have a vision and go against the grain, frankly, because a lot of bottlenecks were happening in telemedicine and robotics back there, and it's still happening. So it certainly was not an easy journey.
Well, first of all, thank you for having me, Henny. And I think that I greatly appreciate the opportunity to share with kind of my history and background and how these things played out. Let me start in the 80s. In the 80s, I studied electrical computer engineering. I specialized in robotics. That was at the University of California at Santa Barbara. So my training was in robotics. And then I decided to start a company, Computer Motion, in 1990 to really kind of use this robotics education I had. And through a series of events, I ended up figuring out surgical robotics was the place to go. It was the beginning of minimally invasive surgery or laparoscopic surgery at that point in time. And that really created an opening for developing surgical robots. So I started the company. It was called Computer Motion. Our first product was called ESOP. ESOP was a robotic arm which held the laparoscope for the laparoscopic surgeon. It was voice controlled. It was the first FDA-cleared surgical robot. And that was kind of the beginning of my journey. That company continued, was pretty successful in that it went public in 1997. And then it ended up merging with Intuitive Surgical in 2003 for a third of the combined company. And but before that merger took place, it was actually in 2001, I was involved with Professor Jacques Moresco out of University of Strasbourg in doing a surgery. It was a single surgery. It's called the Lindbergh operation. It was done September 7th, 2001. And Professor Moresco was sitting in New York City, and he operated on a patient in Strasbourg, France. And so that was the world's first telesurgery. So I think I kind of maybe introduce why I got into surgical robots. That was in the 90s. And so worked on surgical robots all through the 90s, the early 2000s. My company became part of Intuitive Surgical. And then it became time to start something new. And that procedure, that Lindbergh operation, really stuck in my head. And that was like, oh gosh, you can use robots in combination with telecommunication to project expertise, which is the concept of telemedicine. So that's how I got into telemedicine. So in 2003, I started a company called InTouch Health. But it's interesting because the world wasn't ready for telesurgery, okay? The world was barely ready for telemedicine. We decided to do telemedicine over the internet like that was some big revelation back in 2003, but that hadn't been done before. And so we actually had, the internet was the Wild West. We had to put a whole basically cloud infrastructure on top of the internet to do healthcare quality telemedicine. And so I ended up working on telemedicine for starting in about 2003 all the way till 2020 when InTouch Health was bought by Teladoc, as you referenced. And then what's interesting now is actually I do believe now is the time for remote surgery or telesurgery. The market's ready. There's a lot of dynamics which make the timing right. And so I have a new company now called Salvato Health, and we're working to enable remote surgery.
Wow. If the history teaches us one thing is follow your lead and start doing something in this domain, and it will soon start to grow. And for people who are 25 and younger, 2001 is a drastically different time. Okay, the internet is very slow. Like it's way slower than your phone, even in the dead spots. You cannot stream video. You don't have Netflix over the internet. You don't have smartphone. You have Windows. You have some version of Linux. And so doing a simple things like a video communication is not trivial. So frankly, now a lot of the telemedicine builds are go-to-market patient experience tools, right? In 2001, it was a very pure infrastructure play. Like, and you mentioned it. How can I create the cloud that actually does not have a 50-second, 60-second lag, and people can actually see? So, how did you approach that? Because you always have an incredibly innovative clinician. You always can find one of them, right? But very often it's not enough to actually start an innovation. And what we see a lot of the innovation hubs when we start is you will have, cherry pick some of your clinician who are extremely excited to work, but it may end up in grants, it may end up in some research, but it's not end up in a long lasting fundable company, because you go to venture groups and they are not sure how exactly you're going to make money. And then you go to your first customer and they see the value, but they're not sure they want to pay at scale. And certainly in early 2000s, like you have extremely early adopters, and then you had the rest who didn't even hear and just were on the brink of adopting internet itself.
Yeah, so your points are exactly right. So first, there's the technology. How do you deal with the technology? As at that point in time, like if you want to do telemedicine from your home, you had generally a DSL line, and maybe that thing, it depended on how far you were away from the DMARC. Your house was away from the DMARC, and if you were close, you might have a few hundred kilobits per second of bandwidth. And then the up and down was asymmetric. And so the download was maybe a few hundred kilobits. The up was maybe 100 kilobits or something like that. So one of the things we had to solve and work on, and we put a lot of time into, was very good compression, and very fast, good compression of that signal, because the pipe was so skinny then. And so, and that's still part of the technology today, is to be able to do that. And quite honestly, getting a little bit sidetracked, we're now deploying into under-resourced areas of the world, like in sub-Saharan Africa and Southeast Asia, through my nonprofit called World Telehealth Initiative, because we can still work off those little pipes, which they have. So one was making that kind of technology work. Another was obviously things around security. We had to make sure that, because we were dealing with high trust, we're dealing with HIPAA, we're dealing with all the medical grade level capabilities. And so we had to put in all of those types of safeguards in the technology, the accessibility, and how do you make sure that nobody can just beam into some patient's ICU room when they're not supposed to be showing up there. Another capability was in around the whole ease of use, right? And how powerful it is. So for example, we were able to enable doctors to use stethoscopes, to use ultrasounds, to use to patch different vitals through, so that the remote clinician could actually do a real exam. It's not purely just a face-to-face video, and then also look around, look at the pupil of an eye, see it dilate, do capillary refills on finger squeezes and stuff like that. So that's the technical side. So then the market side, as you mentioned, you find early adopters in the early days of telemedicine. We're talking 2004, 5, 6, 7. It was a grant-funded field. It was basically, people thought of it only for rural, underserved areas, and people would get grants for that. So when we got into the market and tried to start selling our telemedicine solution, we'd go and talk to someone, an administrator or someone in a health system hospital. They go, "Oh, you're telemedicine? Well, why don't you take the elevator to the basement, walk past the garbage cans, and there's this doctor back there. I think he's got some kind of grant. He does telemedicine." And so it was not thought at all in terms of systemically around using telemedicine as another delivery modality of healthcare at that point in time. So what we had to do is we had to find use cases which really got the attention of the health systems, where it made sense for them to adopt it in core healthcare, if you will. And we went through a number of different things. For example, telemedicine for the ICU, intensivist to be able to beam in 24/7 in the ICU. Telemedicine to enable early discharges, post-surgical follow-ups. And I think our work back at Yale was ICU-ish, was one of the components. Where we really hit the stride, where it really became a real company, was telestroke. Telestroke at the time was the third leading cause of death, first leading cause of long-term disability, yet only 5% of patients were treated properly. Why is that? It's because you could not get a stroke neurologist to the patient's side quickly to triage the patient, determine what to do. For example, should thrombolytics be administered, or should the patient be moved to a place where mechanical thrombectomy was doable? So telestroke was the application where the clinical value and the economics, and that's a long story as well, we could get those to align. We did that with Yale as well, and it started to kind of grow. And then what happened is, probably in the 2016-17 timeframe, the capability hit the inflection point, and telemedicine started being adopted more systemically by health systems around the country, around the world. And then 2020 hit with the pandemic, and it just shot through the roof. And so that's a little bit of the story, the journey of the telemedicine adoption.
That's a great overview, and especially the part on searching the blockbuster use case, because even through the consulting practices and running innovation groups, you see a lot of despair sometimes from the innovator, where they develop a technology, they coming with a first deployment part, and they don't really hit it, right? Like, no one is adopting it, and they're extremely upset, to the point where they're ready to quit and not willing to experiment. And it's a great lesson that you should persist and try. Like, you need to have a fundamental. And in your case, the fundamental was a technology. I believe there is a great compression algorithm. I believe there is a lot of security we can scale. We just need to ensure that we find the right way to apply that and see where clinicians can apply this. But, when you go into the more niche technology from some innovators, sometimes they may not have as quick of and a higher of a belief in their own self and their technologies, and quit. So it's good to hear that you have to thoughtfully experiment, learn from the failure, not only accept, that clinicians will immediately accept your innovation and start scaling it everywhere. So let's stay on this time of the period before 2020, because frankly, 2020 and the pandemic is a whole another beast for the telemedicine part. We are on an inflection point. And I remember vividly a lot of this because from informatics perspective, as a young medical director of digital health and telemedicine, that was my responsibility to work with clinicians. And it's arguably 15 years since your first transatlantic surgery, and still nobody really wants to do telemedicine because there is an interest from programs. Like we started doing telestroke, and telestroke had good clinical outcomes, and that's actually was the main program we started with. But then you start to get outside of this regular virtual primary care and some of the clinics, and you had a lot of resistance. And resistance usually was, we need more training, we're not sure how to conduct this, let's ensure that we have a proper website matters, right? Webcam matters, and until we have all the necessary policy to do any of that. So it was not a technology, frankly, per se, because technology by then, even the FaceTime, that was already secure enough to be deployed, was ready. A lot of this was actually resistance from clinicians and frankly, some degree of operational resistance because people mostly were not sure how to pay for this, which was leveraged actively. So you are in this part, right? Like you have a growing company that has now great use case, and you see a lot of a potential to scale it. As a leader of the company, like how do you approach this world? Like, do you go to educate the market, or do you go find even more use cases or spend time on clinical trials and selling value? Like, guide us a little bit more through your decision making.
Well, so I think that you mentioned, you said you used the word blockbuster use case. I think in the early stages of a company and a new market, the goal is actually not necessarily to find the blockbuster, it's to find the beachhead. It's to find the first use case where it's repeatable. You can create what the gentleman who wrote Crossing the Jeffrey Moore called the whole solution, and you can then start selling repeatably in a way where you can actually make money. And so you basically find that beachhead, and then you start expanding from the beachhead. And with each new use case, it builds a little bigger market. You know, if you're lucky enough to find a blockbuster, then, you know, that's fantastic. But it's not necessary to find that blockbuster. Take like Intuitive Surgical on the surgical robot side. They found prostate as the target first application, but prostate is not nearly the highest volume procedure anymore that they do, but it allowed them to get into the market. There's hysterectomies, even lap colon hernias, et cetera, colons. And it kind of moves out from there. But so, and then I think that the fact of the matter is people are categorized into early adopters, innovators. I think there's a category generally called early majority, and then there's laggards. So I think sometimes people make the mistake that they got to convince everybody all at once. It's not true, and it's never going to happen. You do have to find your beachhead with the innovators who believe in the beachhead. And then that's where you start matching them up and building. And so I don't know if that answered the question. that, I think that's what you're starting for. What's interesting, so I started InTouch. It was to do telemedicine. I said, yeah, telemedicine's useful everywhere because it gets you the right expertise with the patient much more efficiently, conveniently. It should just go everywhere. Well, I think that statement's true, but that's not how the market adopts. And so this gets back into the beachhead, early adopters, innovators, gets going, that starts expanding, it gets further and further, another beachhead, another one, and they start building like that. For example, it actually, stroke, as we already talked about, even though we started earlier with the ICU, that kind of took a back seat, then came back around. Actually, neonatal consults turned out to be a good one as well, and move forward. Behavioral health, these are all kind of separate use cases. And then when you start getting enough of them, it becomes more of an enterprise level thing. But you cannot go straight, for example, to an enterprise type of solution or sale.
Makes sense. So now when we started talking about the enterprise, let's go to the alignment, because we're in the Real Line Healthcare podcast, and it's mid 2010s, and we're starting to dip our fingers in the telemedicine more and more. The payment is still unclear. So a lot of those use cases that you mentioned, it's a carve-outs or value-based programs, or grants, still very predominant in the industry. So before we talk about what could have government done better, right, from the outcome perspective, from supporting not in innovation, but actually clinical innovation from access perspective, describe the world your company ended up in, and maybe a little bit more for a younger breed of innovators who now expect that everything would be covered by CPT codes, and pretty much upset when their new procedure is not, surprise, surprise, covered by CPT. Describe the world you ended up in, how you guys dealt with that.
So one of the main things holding telemedicine back was lack of reimbursement, as you kind of pointed out. So it was interesting because doctors would typically say, my patients will never accept this, okay? But there's a lot of data showing that patients did accept it, but was not gone. What was kind of unsaid but true was if a doctor saw a patient via telemedicine, they did not get paid. If the patient came into the office and saw them, they did get paid. So it's an economic decision. Now, telestroke. How did telestroke happen? I think I already mentioned the clinical benefit, but the clinical benefit alone doesn't solve, doesn't enable a market to start. So how did telestroke work? It was difficult. It was generally a hub spoke situation. The hub was the bigger hospital. It had stroke neurologists, and it even had interventional neurologists or neurosurgeons. It had a neuroscience program. The spokes did not. So the spokes would not have generally either neurologists or stroke neurologists, but they would typically be within a 90-minute drive radius of the hub hospital. So the hub spoke telestroke model was the hub would actually be our customer and deploy telemedicine into some number of spoke hospitals. And the numbers got as large as 40 spoke hospitals to a hub. Oh. And it was a huge leveraging, because the hub hospital could take that stroke neurologist and have them on call for 40 hospitals. I mean, what a huge leverage that is. And if you think about the whole health system in totality, it's the kind of thing which lowers cost and improves care. But then the stroke neurologists would say, why should I, and they would be paid an on-call fee. And as you know, ERs are, the specialists who cover the ER are paid on call. The stroke neurologist would say, why should I take call for 40 hospitals? Okay. And so we would actually have to convince the administration to actually enhance the call fee coverage for that stroke neurologist, because they're not taking call for one hospital now, they're taking call for 40. So why would the hub hospital do that? The reason they would do that is because the stroke neurologists would take coverage for these 40 hospitals. They would actually consult for potential stroke patients in these outlying spoke hospitals. Some percentage of those patients would need some type of interventional procedure. Those actually are what the hub hospital really wants to do. They've invested in a big neuroscience program. They have interventional neurologists or neurosurgeons. Those are high reimbursing procedures. And so it would allow the transfer in of these patients from the spokes to the hub hospitals, which would drive the economics of the entire thing. Now, you've said, what was the state of affairs in 2010? There's also these laws, which are called anti-kickback and START laws, which are, basically put in place to prevent paying for referrals and paying in using financial incentives to induce additional revenues. So what would have to happen in all of these hub spoke scenarios was they would actually, the legal teams, a lot of these hospitals were not for profits, and they would have to basically write a mission statement showing that this is actually a mission-driven initiative to up the level of care for that larger geography, which is in fact what happened. I mean, it did raise the level of care for it. There's economics which happened because of that. And so hopefully this is coming across, where there's all these problems we had to solve around the regulatory environment, around the payment environment, around the clinical benefits, which actually ultimately drove the market. Now, what happened, what's interesting, is that this started, so more and more published papers were showing how telestroke was benefiting communities and society. And then I forget which regulatory body it was, started creating carve-outs where telestroke was not an issue relative to anti-kickback or START laws. I can't remember the specific regulatory bodies which did that, but the government ended up endorsing this type of solution, even though you could make arguments that it violated these laws.
Wow. So it was a hard process of working around the system to make things happen, which pretty much highlight the point of how easy it is to do nothing.
And then the system adapted. So now there is reimbursement, not just for telestroke, but for telemedicine consults. Now there are carve-outs carve-outs might not be the right word, but there's allowed ways to do telemedicine without running afoul of any of these other regulations. So it's interesting. You kind of have to, get through these barriers you're on a little bit of thin ice, and then the world kind of adapts.
We're not on COVID yet, right? So do you think without COVID push, we would have those, dedicated carve-outs and the massive adoption, or it was something that's actually gave the final push? So now we are, at least for telestroke, in the current state.
I think that what a lot of people say, and I agree with, is what COVID did was accelerate the adoption of telemedicine 5-10 years. And I agree with that. So I think it was happening anyway, because it's better. It's the way having telemedicine in the arsenal of care delivery is a valuable tool. And so, not everything should be done via telemedicine, as in not everything should be done in person. Where's the right balance of those things? So I think that would have happened. But what's very interesting about COVID, so telemedicine was driven by the value propositions, getting the right expertise, right clinician to the patient, the right time, easily, conveniently. COVID came in, different value proposition, allows you to deliver care without fear of contamination or spreading disease. There's a completely different value proposition than what had driven telemedicine. But what happened via COVID is it forced everybody to become very familiar with it. And that's actually then, as COVID subsided, the familiarity kept things going. Teladoc, a company I'm a part-time fellow at, is doing somewhere between, across the whole enterprise, 40 to 50,000 telemedicine consults a day. So it's that's just one company. That's a significant amount of telemedicine consults.
That's a high amount.
Yeah.
One thing in your previous statement that's alarmed me a bit, right, and I just want to point to this, is the clinical benefits was not enough.
Right.
And frankly, it's such a true but painful statement. And when we talk about the realignment, and especially speeding up access, because from the innovator perspective, we can wait 10, 15 years, especially if we know how to run the company and we found some of those use cases. But I'm not sure patients can. And very often this complacency between, we already know that things can be done better, and we know that you can get access to more efficient things, but I'm sorry, clinical efficiency is not enough. So let's wait for political stars align, or for economics to align, or anything else. It's frankly upsetting. So hopefully we can do something around that, where at least from the high yield clinical scenario with AI or telemedicine, or frankly anything that's coming next, the clinical efficiency would play bigger and hopefully the leading role in decision of what should be covered, not politics or economics per se. So 2020, 2019, 2020 is where we all started build telemedicine carts in our hospital garage from anything under the sun, installing, and I remember installing InTouch things and operating system on our equipment we were assembling at Yauheni Health. Certainly an experience of a lifetime. That now, when the primary fear is gone, you can reflect on. Back then it was extremely stressful. And now out of a sudden there is a parity, like something none of us can dream of, right? Like where, I can get paid for my clinical care, which for normal people outside of healthcare is actually very easy concept. If I come to you and I see you the same way I'm seeing you right now, and I'm a licensed physician, and I give you similar level of care, why exactly should I be paid less if it's telemedicine versus if it's in person? If the level of care is similar, no one could really explain that. But now we're in 2020 and there is a parity. Out of a sudden, there is a tremendous demand. So how the world changed?
So as you said, COVID changed the world in many ways. In the healthcare, it pulled telemedicine forward 5 to 10 years. I have a slide that I use in presentations sometimes that I got from Mayo Clinic. And it has a graph of telemedicine consults per day on a weekly basis. Okay. So for Mayo Clinic, March 2020, right? So in February 2020, they were doing 400 to 500 consults a day, telemedicine consults a day. And then it shows the COVID, it was right around mid-March 2020, it jumped from 400 to 500 a day to 8,000. So over a period of a couple of weeks, it went up 20-fold in terms of the utilization. And so that's the point in time you're referring to at Yale, and every health system around the country and around the world was dealing with this. And quite honestly, at InTouch, we had always put a lot of buffer in our system to handle, maybe surges of even 50% or 100% of usage. But this is 2,000%, right? Jumping in weeks. So our systems, to be frank, they were breaking, and it was a scramble time. But then on the governmental side, things were put into place really quick, like basically payment, because those physicians now were just seeing patients only remote. How do you make a living if there's no payment on that? So they quickly put that in place. And what's been happening since COVID, as I'm sure you know, is the extension of those payment remedies. And to be frank, I don't know the specifics very well, but there's been an ongoing evolution of that payment structure, of which there's still good payment for telemedicine.
And selfish plug for future episode, we actually will have an episode when we talk about the extension and what's going to be happening.
Yeah, I'll have to listen to that one
in the next months. But the personal anecdote around this time, I was still director of innovation for our ambulatory group, and a lot of our job was to go practice by practice, because we started urgent care clinic, and is to actually find the practice, please, shift some of your volume into telemedicine. We actually internally carve out some of the payments for clinicians for lower acuity. Created this incredible economic calculator, convinced leadership that yes, you should cover, even if it's not fully paid, you should at least. And it was hard, because people were saying, oh, I need more training for this. Maybe let's do 3-4 weeks of training, shoulder level training, right? So I know where to click and all of this. And then COVID started. And we did one online training with hundreds of docs on a Zoom call, like hundreds of docs. And then we went live next day. And guess what? No calls to support line. We were sleeping and waiting for every doctor under the sun to call. Of course, then technical things started to happen, right? Because you cannot scale this and all this. And we ended up in a multiple telemedicine solution world where this clinic is doing one vendor, this one is easier. But out of a sudden, all this angst of, how I'm going to practice here, I need someone next to me to telling me where to click, was not an issue anymore. Because the interesting part about this, and I think that's true for many innovation, is out of a sudden from this, pie in the sky new technology that I need to test, but I have an alternative to adoption, it became this mass telephone. I have to do it. It is what it is. Right? It's a telemedicine. It's nothing special. I have to practice, as you mentioned. So, unfortunately, this time also was a time of inflated expectation. If you look on the way all the digital health companies raised money on their fluffy valuation, as we know by now, and all this true optimism where, we're going to sustain the space, right, through all of the 2000s. We're only in 2025. And it's pretty evident we're not on the same hockey stick digital health telemedicine trajectory we were hoping in early 2020, 2021. So what happened? If you look between that, did we try to adopt too much? Where we were greedy on asking for too much valuation? Because by now, we've seen a lot of the company that unfortunately folded on great ideas. Some companies who sold their telemedicine business, a lot of remote patient monitoring programs are actually scaling down to almost pre-COVID level. And there is still an optimism that telemedicine is here to stay, and that we have a not just extension, but actually meaningful way to pay for this. But arguably, a lot of people saying that we did lose significant amount of steam.
Well, so I think this is where people need to stand back a little and reflect in totality what's going on. So first of all, telemedicine utilization is way higher now than pre-COVID. As I mentioned already, Teladoc is doing 40 to 50,000 telemedicine consults a day right now. Okay, so that's not a small number. I don't have the exact numbers off the top of my head, but there's a level. It amplified tremendously during COVID, and it's pulled back some. It's pulled back even a reasonable amount, but that's still significantly higher than where it was. Now, what's interesting is, for example, stock prices, valuations of companies, digital health companies. The market just likes growth, right? And it's unreasonable to assume that you can go through a period where it's growing, it's in the early adopter cycle, and then because of a black swan event like COVID, it goes to, complete adoption, and then the black swan event's over, and it pulls back to something more normalized. That's a downward slope. It's just, that's not. If you just think about it, that's what has to happen. And so, the market and investors and stuff see a downward slope. Everybody runs from downward slopes. But in fact, that's, in my opinion, stabilized, and it's coming back out, but it takes a while for the market to adapt to that as well. So, the area of digital health, virtual care, telemedicine, all these things, my personal belief still has a huge future. I think we're on, step 2 or 3 out of a 10-step evolution. And the whole COVID anomaly is still in the digested process, and it's going to take a little bit longer to work out. Take, for example, work from home, okay? COVID happened. Everyone's working from home, 100%. We are, in my opinion, we're not through that cycle yet in terms of companies, as we see in the news, companies requiring their employees to come back into the office. So that's still playing out. I think that's still going to play out for another maybe few years or so before it returns to some kind of normality. I think telemedicine, virtual care is still in that cycle. So you can't expect it to recover and stabilize too fast.
It's a great perspective, because people certainly get scared, but frankly get scared based on not rational facts, is even double irrational. So from that perspective, we need to take the momentum that we were able to build and the wins and keep growing in that. And frankly, work for home right now, it's interesting that's likely on the more conservative part, right? Because there is a big pushback on, I want to bring everyone back. I want to ensure that I'm controlling, and without endorsing any company, some company actually saying we're not babysitters, right? Like we trust our employers, so please work from the place where you're more effective. And if it's home, then it's home. And to a certain degree, that's hopefully a part with telemedicine, because we need to allow our clinical system to find the more efficient way to deliver highest quality care. And if it's virtual hospital and if it's telemedicine program, so be it. Because I'm not sure you actually can babysit around this. And data analytics can tell you way better story, right? That's your individual observed anecdotes.
Well, just piggybacking on top of that. So we have regular brick and mortar care that existed, pre-telemedicine, pre-COVID, et cetera. We now know you can do virtual care, and COVID proved that, and that we actually were delivering healthcare all through that process. Now we're in the process of hybrid care. Some things should be done in brick and mortar environments, some things should be done remote, but it's taken a while to figure out how to optimize that. And I think that's reasonable. And so that's, in my opinion, that's the stage we're at.
And do you think, who should take the leading role on this? Because when you talk with a clinician, especially a clinician working on hospital and home programs, or a clinician trying to expand into new use cases that are disease specific, a lot of the time, the hardest part is actually carve out this coverage part, unless it's covered by your value-based agreements or something where you can strike the deal directly with employers or insurers. Find a way to actually deliver this care. Do you think the government need to find a easier way to innovate and experiment and for us to ultimately generate clinical outcomes? Because a lot of those programs do require significantly higher number of observation to actually see the population level outcomes. And that's not something that you can support with NIH grants. That's not the N you can generate. So if you're saying I need more observation to actually find my clinical effectiveness and economic impact on this, maybe it's time to start carving out interesting and better programs that can help you to pay for those experimentation.
I think it's a multifactorial, multidimensional problem to solve. And so if I were to paraphrase back what you were saying, I think is how do we give the system sufficient ability to experiment and drive towards an improved effectiveness for the healthcare delivery system. And I think that's not just now. I was fortunately had the opportunity to be part of a National Academy study, and it was titled "The Learning Healthcare System." I think it was published a decade ago or so. In which case, the goal of the healthcare system, healthcare delivery system, the goal should not be, oh, here's the ideal way to do it, and let's do that. The goal is how do you put in place the system in place so it's always improving, it's always adapting and improving, and that's very hard. And but I think that even though it's hard, it's something we should continue to strive for and continue to work to improve upon, and we have to, because healthcare costs are so high, and they're only going to get higher, with increased aging population, all these things. And so I find it an exciting, challenging problem to work on.
Let's talk about the future. So now you're working on new generation of a surgical robotic project, and we still have a high hopes for telemedicine and remote procedures. So, and AI is certainly feels like everywhere for now. So where do you think we're going to go in 10, 15 years? What's your bold bet? How the healthcare will look?
Well, so first off, as I mentioned, I've got a new company called Savado, which is working to enable remote surgery and procedures. So surgery and procedures, and procedures being even diagnostic procedures or interventional procedures in addition to surgical procedures. It's a huge expense of the healthcare system. It's one in which quality is not distributed very easily. And then our surgeons, our interventionalists are perhaps in the shortest of supply of different types of people in the healthcare system. And so enabling these types of surgeries and procedures to be used remotely should be able to improve access to quality of care for everybody and lower costs. So I'm a huge believer that that's going to be part of the healthcare system in the next 5-10 years. And then I'm a big believer in digital health, basically the discussion we've been having, telemedicine, and the ability to optimize hybrid care so that when a patient needs to access care through their phone or a computer, they do so, or when they have to drive to a clinic or hospital, they do so. You incorporated a new term just a second ago, which was AI. And I think that's a very powerful new tool that fits in all of these things we're talking about. And it's foundational to the transformation to digital health. When you have digital health, you can apply AI to it because it's digitized, and now you can apply computer processing on it. And I think that the AI, in a sense, can be can positively impact things in a few different ways. One, it can be added value to the clinicians, whether it's giving the clinician, real-time consultative information, or it's even improving the diagnostic capabilities or therapeutic capabilities of that clinician. That's kind of one dimension in which AI, I strongly believe, will become more and more incorporated. Another dimension is the AI helping the patient directly, whether it's just basically a direct interface for the patient to get the healthcare questions answered they need, and or help just educate them on how to take care of their chronic disease or what have you. And then, in terms of the whole remote procedures and surgery side, will AI be very helpful in automating certain capabilities? And I do not believe surgery and procedures in general will be just purely automated in the next decade or two. But I do think that there can be automative steps in terms of these procedures and surgery, which can be assisted by AI. And then a lot of the back end work, the administrative work, which is so tedious and burns out our healthcare staff and teams, I think a lot of that burden can be eliminated too. So those are, hopefully some helpful comments.
I like how casually you're talking about something that's sci-fi for many, many people, including listener, about automating some step of surgeries. Just a reminder, a decade ago, we're talking about, will I be able to see a patient via camera? And now we're talking about, okay, will surgical robot in a clinical surgical environment will be able to close my wound, for example, assist me with certain part of this, which is beyond sci-fi, to be honest. So it's certainly in a very exciting direction. I think it's the snowball of the more data we generate, the better sensing are inside the surgical procedure, the more we know about what's happening from the imaging perspective, from a sensing perspective, the more advanced systems will be coming, because what we're able to develop now are smarter foundational models. And a lot of people know and think mostly in large language models, because all the open AI progress and what we're seeing from Meta in Llama and other. But when you step outside of the traditional language models, you see tremendous progress in actually physics models and a foundational model that can predict, the world around you. And it would be a very interesting decade for innovators in robotics and in the remote presence. So we're almost at the end of our episodes, and have to say the hour flew by very fast. The most traditional part of the Realign Healthcare podcast is, if you had a magic wand, what is the single thing you would change in our healthcare system that will better align it with the need of everybody, or frankly, at least one of the group?
The single thing I would change in the healthcare system, I think that I'm going to tell you what I would change, but I'm not going to tell you how because I don't know how. The issue with healthcare, the healthcare system, and people a lot smarter than I know this, much better than I do, is you don't have market forces continually driving improved value, as in what you get for how much it costs. And I think that's the fundamental problem of our healthcare system, which makes it so that prices just keep going up, and there's no way to curb that. So the way the healthcare system needs to be realigned is so that ultimately the consumer, the problem is it's so complicated. So you shop for a car, everybody knows how to, what they're looking for and can figure out how they want to create what they're willing to pay versus the value, buy clothes or food or whatever. Healthcare's got to figure out a way where market forces are constantly making it better for the relative cost. That's what I would try to figure out how to do. And then
I like it. Yeah, that's great.
Yeah. Well, so I don't know how to do that. I mean, there's all the fee for service going to value-based care is the terminology, but how to make it do what I just said is not simple.
So we need to increase sensitivity of our healthcare systems and insurers into the feedback and the market forces from end consumer, because we historically been protecting them and carving out, because trying to change your insurance outside of a cycle, or for anyone who changed their primary care physician or relocate it and just try to, even in 2025, right, transfer the medical records from the place A to place B. We have a lot of friction in the system, despite all of the technology innovation we worked on. So the market feedback is not there. And a lot of the fears from a consumerism driven, where people will vote with their feet, didn't actually end up being true. We see retail clinics being closed and people didn't really go in a more convenient location. It would be good to have a feedback loop that's way more effective and ideally hit when it hurts, which means in reimbursement to both insurance and clinicians.
I think that's right.
Great. Thank you for joining us. It's been an amazing episode, and hopefully in a few years, and maybe 5 or 10 years, you'll join us again to talk about now progress in the robotics and how the next wave of adoption of AI-assisted surgeries and now driving the transformation of the clinical care.
I will look forward to that.